Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces that are designed for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com for your shoulder brace requirements. We've also just expanded now to the UK, so if you live in the UK or Europe, you can get your shoulder braces much more quickly. So check us out at flawlessmotion.co.uk and you can check out our shoulder braces there. Cheers. Good morning, everybody. Today, it's my great pleasure to welcome Michel Mertens to the Glenohumeral Gurus podcast so that we can learn everything he knows right now about frozen shoulder. And I'm really looking forward to digging into this. Michel, can you introduce yourself to the audience? Tell us about your physio career, how you got to be doing what it is you are now, and your fascination with frozen shoulder.
Yes, of course. First of all, thank you for the invitation to be here and to be on this chat. I started my career as a physical therapist. After I graduated, I also did a master in human movement sciences, and then I started working in a private practice for almost 10 years. I developed expertise in several points in knee rehabilitation, obstructive pulmonary disease, peripheral arterial disease. Then I started with a part-time education for sports physical therapy. And then after a 10-year, I transferred to academia, where I started as a graduate and research assistant, where I combined educational tasks with with conducting a PhD, which I finished in 2023, which was on the frozen shoulder, the topic of today. So it's really an interesting and very broad topic to discuss. So looking forward to it.
Yeah, me too. How did that come about? Like, why frozen shoulder for you? How was that? Why? How did that evolve?
Well, it was within the job application that they wanted to do something in shoulder disorders, and
Yes.
in general, my interest is quite broad, and I just
Mhm.
started with more expertise within clinical practice in the shoulder, so that was quite a good development.
Yes.
And then they Philip and Mira told me something about the frozen shoulder, about the project that was, yeah, some kind of running, and if I would continue that. And
Mm.
I really got interested in in that topic. It was really huge, and
Yeah.
yeah, and
Yeah, it's been a
during the way,
fantastic opportunity for you, hasn't it? And now I'm
yes,
really
it was.
excited to hear, like, just delving into one thing in all its depth makes, yeah, you couldn't talk about this to us for hours, can you? I mean,
Yeah, for
it's
sure. There's so much
wonderful.
to tell about.
Yeah, I'm
It's really
excited.
amazing.
Yeah,
Yeah,
cool. It's also
and
my
there's still.
pleasure to welcome my co-host today, my friend and colleague, Dr. Angela Cadogan. Ange, welcome to the Glenohumeral Gurus podcast again.
Thank you very much, Margie. Very nice to be back.
Yes. Now I know you have a special interest in frozen shoulder, and we were chatting around, and I mentioned that I was going to meet with Michelle, and you wanted to pop along and ask him also some questions.
Yes, I did. Thanks. Yeah, so as well as being a specialist shoulder physio, I'm here representing the patient group. I have the dubious honor of having a frozen shoulder myself. I thought that being a shoulder physio would give me automatic immunity, but apparently that is not the case. So here I
Turns out
am
you're
with my
just
stiff
human.
shoulder.
Yes,
It's really to
right.
get some free advice, I guess, and
Yeah.
just learn more from I guess a physio and across all aspects of frozen shoulder. But just I guess a bit of a patient perspective as well.
It's interesting, eh? And it's going to be, and this is the first of our series on frozen shoulder. But I have so many things to talk to Michelle about that we've split this into two podcasts. So the first part will be on some of the clinical course that he's studied, and then we'll move into the second part of the podcast because I've got this feeling it's going to take a while to dig into all this information. Michelle, firstly, did you want to define frozen shoulder for the audience broadly? What is it that exactly that the clinician should be looking for, and what are we talking about exactly?
Yeah, in the general way, we use the definition of Kelly from the guideline,
Mm-hmm.
in which we see that there is at least for 1 month progressive or stable complaints. So when the complaints are decreasing in the last months, we actually say it's probably not a frozen shoulder, or at least not at that time point. So maybe it can evolve afterwards to a frozen shoulder.
Yes.
So we have to be the range of motion restrictions into at least 3 movement planes to
Mm-hmm.
at least 25% decreased, and external rotation at least 50% decreased compared to the other side.
Yes.
Um, so I think that are the most important elements to define the frozen shoulder, at least for now. And
Mm-hmm.
that is also immediately the most difficult point, because that is only the point from where we can define and can diagnose the frozen shoulder. So we can only diagnose it from the point that the movement restriction is there.
Yes.
So before that time, we can only suspect a potential frozen shoulder, or that it will be developed in the future.
Mm.
But we have no tools to diagnose it before that point, and that makes it quite difficult for clinicians to focus on what should I do. Is it a frozen
Yeah.
shoulder? Is it not?
Yeah.
Yeah,
And so
that's hard.
let me recap because I think that's a really important point for people to take. You're saying progressively in the last month they are progressively worsening, and with regards to pain or just their range of movement or
Both, or at least be
both.
stable, so that there should not be a decrease in the complaints. That's the most
Okay.
important. When the
Okay.
complaints decrease during the last month,
Yes.
then we say at that time point it's probably not a frozen shoulder, or not yet. So it still can develop,
Be developing.
but yeah, and that's the difficult point.
Yeah, it really is, isn't it? Then, because I traditionally think about it in frozen shoulder in terms of phases, and not always the restriction in the range of movement is present in those earlier phases. So, should I keep thinking? I guess, firstly, is that still correct, the way that I think about that? Because,
Yes, it is still quite often used, the 3 or 4 phases, but
hmm.
that phases are clinically quite difficult, because the
Yes.
phases are defined based on the pathoanatomical issues within the shoulder, but we
Mm,
cannot see that clinically. So also because of that, the irritability levels are introduced to have a more clinical way that we can use during our treatment. So I think that is an important evolvement, um, together with the two-phase definition that Jeremy Lewis introduced,
mm,
pain dominant or stiffness dominant.
yes,
It is also more clinically relevant to use that compared to the 3 or 4 phases that were described previously.
yes.
And of course, the phases are correct, or at least probably correct, based on what is seen during arthroscopy and imaging.
Mm-hmm.
But that is something very hard to do in clinical practice. And um, I don't think it's really useful to put everyone on imaging to say or to diagnose whether it's a frozen shoulder or not.
Mm,
I think the clinical pattern is more important. So it starts with very intense pain,
yeah.
and then the pain may decrease a little bit, and then in one time there is a movement restriction,
Mm.
and from that point we say, okay, now we can diagnose it as a frozen shoulder. which we may already have suspect in the period before, but we were
Mm.
not sure about it.
So
And it
which
would
stage
be,
we're halfway through the two phases of there by the time we've made our diagnosis.
yes, yes. In some instances, indeed, we are already in the second phase
Mm.
or at the end of the early phase
Mm.
before we can diagnose it. So it would be very nice and very helpful if we could
Mm.
find a tool to diagnose the frozen shoulder in an earlier stage. And
Yes.
there are some ways to do it with ultrasound, but it is not really confirmed already that we can say, well, with ultrasound, we can really say it's a frozen shoulder. So that would also be some future research to see,
Mm.
all right, we
Mm.
put many patients with shoulder disorders in the ultrasound. We see some characteristics. We noted the characteristics, and then we follow them over time and see who of them develops a frozen shoulder. And we also did the coracoid pain test. That's one of the very specific tests that is available. I think
Mhm.
it's even the only one for frozen shoulder. It was developed by Carbone from Italy, the group of Carbone. And what they did was with their fingers, they gave pressure at 3 points at the coracoid process, at the acromioclavicular joint, and then 2 centimeters just below, if I'm correct. And then they say, well, when there is more pain at one point compared to the others, then it is a frozen shoulder. And they did that in a very big group with all different shoulder disorders, but they only used the thumb and the finger, and they did not standardize the pressure. So that was one of the main points, which makes it difficult if you already know, or yeah, do you apply the same pressure with all the
Yes.
patients or not? So we try to reproduce that in a slightly different way. So we used an algometer, and
Hmm.
then we applied a pressure of 4 kilograms at the same points, and
Yes.
we compared the results to a healthy control group. So it was not the most strongest design, but at least we had some information about it.
Yeah.
And this might also be an interesting test to already apply in a really early stage, and
Mm.
then again follow them up and see if which group develops a frozen shoulder, and if that group is really different in the coracoid pain test
Yes.
compared to the other diagnosis. And yeah, if we can do that and we can find a difference, that might
Yeah.
be, it's my dream to see that
That
we
is
have an early diagnostic tool to define or to diagnose the frozen shoulder.
I'm loving your passion for this is really wonderful. Do you think? And so right now, the message to clinicians is they should wait to see what the findings are of this future study on the palpation, coracoid process palpation and AC joint and lateral. Or you think that's something they should wait until you've done more research in that space, or they should, what's your advice?
Yeah, we did not find the same results as that Carbone found for that same method. So we
Mm.
also applied two different other methods to compare it to the other side and to
Mhm.
compare what was the other one, or to use a stable pain level.
Yeah.
And that were different results, but because we did not have other shoulder disorders within our group, it's more difficult to say that the test will be useful or that one of the three methods is more useful than the other one. So
Yeah.
therefore, I think it's better to have to wait with the test and
Yes.
uh,
Okay.
until more and better results are available.
Yeah. So right now, that's an interesting thing that they might observe, but really we don't know in terms of its predictive validity or really how valid or
Yes,
that it
yes.
is. Yeah.
Can I just ask
Helen,
a question,
sorry,
Michelle?
Ange.
Sorry, just a follow-up question on that one. So I guess is the rationale behind that test that the coracoid, I guess the attachment of that coracohumeral ligament being one of the structures that's most affected with the inflammatory process, and that would be more tender, is that correct, than the other
Yes,
points, than the AC joint and the other one? Yeah.
That's correct. Yes, indeed.
Yeah,
So because the coracohumeral joint is mostly involved, that point will be more painful compared to the other ones, and that would make the difference to see, well, if that point is more painful than the other ones, then we have a positive test, and it would suggest that it's a frozen shoulder.
Mhm. I can certainly verify that from a patient perspective.
Your tender on palpation, Ange.
On coracoid.
And so, from moving there into these longitudinal studies, because you talked, Michelle, about in that early stage trying to actually predict who it might be, what can you tell us about these other longitudinal studies that you've done?
Yeah, we compared many variables over 9 months, so from baseline to 9 months, and we followed them up we measured them at 3 months, 6 months, and 9 months to see how it develops over time.
Yeah.
Because from the beginning, based on the study of Reeves, it was always told, well, we should wait with treatment, and the most treatment will be in the later phases, and then we can continue. And then there came the review of Wong, who indicated, well, apparently that is what we always say and taught, but there is some evidence that there is more improvement in the early stages compared to the later stages. So we should not wait with our treatment, but we should start early with it. And then we found the same pattern. So there is rather an early improvement in almost all variables that we measured, and then over time it flattens. So more towards the 6 and the 9 months, the improvement is less compared to the beginning. And what I think that is the most important is that we do not need already with very intense treatments, but when we inform the patient about the prognosis and what they can and what they cannot do in the early stages, they will already have a large improvement without being physically active or coming to the physical therapist. They can do very much themselves. And if we inform them about it, I think we can already prevent that they will have large movement restrictions in later phases.
Because explain that to me. Because of the role of education, you think moderate somehow?
If we go back to the study of Reeves, and
Yes.
what they did in the study of Reeves was, right, you have very much pain, keep your arm close to your body, don't move with it, wait until
Yes.
the pain removes, and then when the pain is gone, then you can start moving again. But what we
Yes.
also see in patients after surgery, when they keep the arm close or when they do not move, they will get the movement restriction. So when you do not move, you will get a movement restriction.
Okay.
That makes sense.
Yeah.
So when we know that it's a frozen shoulder and we can inform the patient about moving within their pain-free range of motion and just keep the movement as it is at that time, I think we can prevent the increasing the movement restriction. So that is one important point. A second important point, I think, is that the way that we apply as physical therapists, that we apply our manual therapy, our mobilization techniques, I think there is still quite two parts. One part say, well, we have to move beyond the pain threshold, and the other say, no, we have to still be below the pain threshold. And I think that is the better part, especially in the early phase when inflammation is still there, because when we start moving beyond the pain threshold and we will activate the myofibroblasts, then we will increase the movement restriction, because myofibroblasts respond to tension, to stress. So when we stress the myofibroblasts, we probably increase the movement restriction. So in the inflammatory phase, the early phase, I think we just should stay within the pain-free range of motion. And how do we know if we are still in the inflammatory phase? That's what we can do with the irritability levels. So if you are in high irritability, you can do everything that you want unless it is pain-free and you do not have any response on your activity that you have done afterwards. That is what we generally advise.
Yes.
When we transfer to moderate irritability, you can say, okay, you can have some response of the activity and it may last for 6 hours, but then it should be left out. And
Yeah.
if it's still there, then the activity was too intense. So next time, less intensive, and the same applies for the mobilization techniques. In the high irritability, just keep it low, just move quite often within the pain-free range of motion. When the patient transfers to the moderate irritability, you can have some response in the case of in pain, and then see how the patient responds to that. And if there is less than 6 hours response, then next time you can do the same intensity, or maybe try a little bit higher. And of course, in the low irritability, we will move many times towards the end range because pain is less of an issue in that phase.
Can I just ask the key factors that would define low, moderate, and high irritability? Are
There
there
are
some key
also
factors that clinicians should be thinking of? How are they going to know what phase they're in is my question.
So it's also in the guideline, in the guideline of Kelly. So we have the 3 phases. They are mostly defined based on how many disabilities are present, the pain intensity that is present. Is there a large difference between active and passive range of motion? Because when there is a large difference between it, it might also be that the active range of motion is rather limited because of pain or because of muscle guarding, etc. And then if there is night pain present, yes or no. And if the pain is present in the end ranges or during the whole range of motion, that also are some key variables. And then depending on the responses of the patients, it will be high, moderate, or low.
Okay, so people could look to that paper really to help define those different levels. My practice,
partly because not all the levels are already concretely mentioned. So it's rather for high irritability, the disability should be high, but it is not defined on the SPARI, on the DASH, what is high. Is it above 50? Is it above 75? So that is still a little bit arbitrary and depending on the interpretation of the clinician.
Okay, so they should use their own clinical guidance, judgment really to decide whether they are low, moderate, or high irritability there.
Yes.
Though, Ange looks like she has a question. Is that raising your pen?
It was. Raising my pen. Thank you. Michelle, it's really interesting. I'd like to go back just to a point you raised slightly before the irritability section. You mentioned about the post-operative frozen shoulder and potentially if people are keeping their arm immobile and that might lead to more stiffness. Do we know, is there a difference in the pathology between say a primary frozen shoulder and a secondary, say a post-surgical or a post-traumatic? Do they have the same pathologic mechanisms and therefore the same clinical course and prognosis, or are they different pathologies?
I think they are different because the way of developing the frozen shoulder is different. Post surgery, we have a clear point where the frozen shoulder may develop from. With all the other ones, we do not have any idea when it actually started. Most people say, well, I hit my shoulder against the doorpost and a few weeks later I couldn't move anymore. And that is something common that most or many people say, just all day trauma, nothing very special. That is the point that it's actually started, or that they indicate that it started. And that makes it very, very interesting, because when it's only such a minor trauma that might be the starting point of developing a frozen shoulder, I think there might be some underlying mechanisms that are already present that predisposes the patient to developing a frozen shoulder. and I think those elements are quite interesting for the future.
And so this sort of sets up why you undertook then the prognostic factors. You, from what I understood, you measured a range of factors at baseline and then followed them up to see which ones would predict whether people developed a frozen shoulder. Is that true? Is that the nature?
Yeah, it's not that we looked at if they developed the frozen shoulder. They already had the frozen shoulder, so we measured some
Okay.
items, and then we looked at what is the outcome. Are there any variables that could predict the outcome of that period? And there were we did not intervene in interventions, so some people got interventions, some patients did not get any interventions, or very small interventions. So we just recorded it that they had an intervention, and that's it.
Yeah.
So we included that as a covariate. And then what we actually found was that there were indeed some variables that predicted a better or a worse outcome in quality of life and in disabilities.
So it wasn't so much a study looking to see whether you were going to develop a frozen shoulder. It wasn't predicting that. It was predicting the outcome once you had been diagnosed for a frozen shoulder, predicting your
Yes,
outcome. Is that correct?
yes,
Tell us
yes.
about that then. What's important? What is going to predict outcome? If once you have your diagnosis, what should clinicians know from your work?
Yeah, there were some surprising findings, because when patients have or had more external rotation range of motion, they had a worse outcome in quality of life or physical functioning and pain, which was actually quite surprising, because when you have larger range of motion and external rotation, you would expect that the quality of life would also be higher, but
Yeah.
that was not the case. And one of the hypotheses that we had was that it was maybe related to those who had more restricted external rotation. They may have received also more treatment that in the end resulted in a better quality of life. But we do not have any information about the frequency and duration of the treatment, so we cannot confirm this hypothesis. So that is something that we should investigate in the future
Yes.
if possible. Yeah.
Yeah, as to why more movement actually gave people worse quality of life. It gave them
Yeah.
more pain, perhaps. There was nothing there, didn't the people who had more external rotation then didn't also have more pain? Or
Yeah, I don't know, because we also measured some quantitative sensory testing variables that we included
Mhm.
in that, and none of those quantitative sensory testing variables predicted any of the quality of life or disability outcomes. So
Yeah.
yeah, it's quite surprising that this result came out.
I think which is so wonderful about your contribution in this space, isn't it? Because our expectation was that it would be the other way round, and actually
Yeah,
there's something new to find here, isn't there? Which we
yeah.
we look forward to circling back in a few years, maybe, to see. You did talk around though diabetes, from what I understand in that study. Is that correct?
Yes, diabetes was also one of the predictors that we included, and it predicted indeed disability and the physical functioning, and that was more logic that we have found that if
Yeah.
having diabetes resulted in more disabilities, and it also had a lower quality of life in physical functioning. So that was not really surprising. And it is
Mm.
also something that is already confirmed in several studies. Diabetes has a role in frozen shoulder,
Yeah. Can
maybe
you
in developing.
explain? Yeah. Can you explain to me and other clinicians how that works? What's the theory behind that? Why is that?
Well,
Broadly,
it may
broadly
not
speaking, I don't want
be.
to put you on the spot.
No, 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 no. I have an idea about it, and maybe it's not specifically having the diagnosis of frozen shoulder,
Mm,
but maybe it is also those people who are pre-diabetic who
yes.
not yet know that they will develop diabetes, they may also already predisposed to developing a frozen shoulder. And that is something that we also want to explore in future studies. Is it rather more important to know the glycosylated hemoglobin level or the diagnosis having of frozen shoulder? And if we know that a higher level of glycosylated hemoglobin is already predisposing to developing a frozen shoulder, combined with maybe some other metabolic features, then we should maybe focus rather on the underlying mechanisms and start treating those mechanisms instead of focusing on the shoulder. And that is also something that may not be solely for frozen shoulder, but maybe partly also for rotator cuff related shoulder pain, because we see a similar pattern in the underlying mechanisms in that population. And if we know that those underlying mechanisms may play a role in the development and in the outcomes after treatment, and then we can explain why the results are heterogeneous as they are now.
Yes, yes.
Because we see very much heterogeneity in the outcomes. Some people recover within a year, maybe 9 months, while others have complaints for 2 years, 3 years, 4 years, even 7 years.
Yeah.
After which some people have even severe pain.
Because we've previously been told this is a self-limiting condition, isn't it? That after 2 years, then you'll have a frozen shoulder for 2 years, and then it will be gone. But that's actually not what we find, is it? That's or
Start at
is
least
it?
not.
Is that should we keep? I guess I'm looking to you to debunk my myths that I have developed. Is that true?
Well, first of all, it's not true for all the patients, because even after 7 years, a subset has still severe complaints. So self-limiting does not apply to everyone. But next, what is the definition of self-limiting? That's the next point. And if we consider self-limiting as recovering without any treatment, I don't think frozen shoulder is a self-limiting disease, because when we already give some information about the frozen shoulder, we already have some part of intervention applied in the first instance.
Yes.
So that's the first part. And I don't think we should say to those people with a frozen shoulder, oh, just wait, you will recover. No, we have to inform them about the process, about the prognosis. We have to inform them about what we know. Many people have questions because the pain in the first period is so debilitating. They want to know what is going on. They are afraid to move. But in the end, they have to move, because when you move, you will start, or you will keep continuing the blood flow. And blood flow is important for inflammation, removing inflammation. We know how important the blood flow is. So if we can facilitate the blood flow by moving the arm and the shoulder within the pain-free range of motion, I think that's the first starting point of recovery.
Yeah, okay. It's probably
And that
also
is
quite
something,
empowering for people too, to be reassured that they can move, because
yeah,
like Ange, I have had a frozen shoulder a few years ago now, and so now I have no recall. But what I do remember is how incredibly painful it was. But if you are moving within that pain-free range, then you are reassured that at least you can move in some places without the pain.
yeah. And the next point, if you cannot move with your shoulder and you have, for example, diabetes, or you have thyroid disease, or you have maybe hypertension, or maybe some cardiovascular disease, go out for a walk, do some aerobic exercises, just be in movement. And then you also have some blood flow. You can, during walking, you can move your arm next to your body within the painful range of motion. Usually that movement is possible. And then, of course, you have many other benefits of just walking around. It's not
Yes,
only for the shoulder, it's also
yes,
mental health that improves, just full body that will have their movement. I
yes,
think that
yes.
it's important.
Yes. And so just I want to think about then when I'm thinking about diagnosing a frozen shoulder, we've talked about those two different phases. We've talked about really the diagnosis only can be, you can really be sure when you start moving through, when you start losing that movement. I typically ask people on initial assessment whether they have diabetes, whether they have a thyroid condition, whether they have like the cardiovascular factors, hypertension that you talked about. And I also asked them about periods of stress because I think we saw a lot of frozen shoulders after all our COVID lockdowns here in New Zealand. Is there anything you've learned around that as a factor of psychosocial distress? You
Yeah, there are some studies that investigated psychosocial factors like depression,
as a
and
risk
also
factor.
yes, as a risk factor, and uh, let's see, also probably as a result. But yeah,
Mm.
when the depression develops afterwards, it may be more related to debilitating pain.
Yes.
But but especially for developing the frozen shoulder, there are some indications that depression also play a role in that.
Yeah.
And if we consider all the variables that we just mentioned,
Mm.
there is one common element in all of them, and that's chronic low-grade inflammation.
Yeah, okay. And
So
that's
what?
the driving factor, you think?
Maybe, or
Maybe, maybe.
yeah, or maybe not the driving factor, but an important predisposing factor. And
Yes.
many people do not know if they have low-grade inflammation or not.
Mm.
But low-grade inflammation is present in
All those
hypertension, in
conditions.
diabetes, in depression, in COVID. It's
Yes.
also inflammation, low-grade inflammation.
Mm.
And that would make sense why people hit their shoulder against the doorpost or against whatever. That is
Yeah.
the point that starts my pain. That's the point where probably my frozen shoulder started.
Yeah, okay.
That was the drop into the bucket
Yes.
that
Yeah.
it walks over.
What do you think, Ange?
Why does it affect the shoulder? And that's not a question I expect you necessarily to have the answer to, Michelle, but this has been a fascinating question for me is with the low-grade inflammation, all of those risk factors, which are all systemic risk factors, why the shoulder and nowhere else? Do we have any
Well,
answers to that question?
I cannot answer that, but we see it also in the hip. We also have an adhesive capsulitis of the hip, but that's maybe less common compared
Mm.
to the shoulder.
Mm.
And I don't know if the pattern is similar to the shoulder. But
Mm.
that's an interesting question. Why the shoulder? Why not the elbow?
Yeah.
Mm.
Yeah.
Why?
Why
Why?
does it happen?
I did
Yeah.
do when you have a frozen shoulder and you're awake at 3 o'clock every morning for months on end, you have a lot of time to read. And I did read something somewhere about it potentially being a failed immune response. So, in other words, there's some kind of stimulus, I guess, trauma, oxidative stress, surgery. There is I think the synovium and the capsule of the shoulder are apparently very rich with immune cells. So potentially,
Mm.
is that a potential mechanism, I guess, underlying this? We just get a massive immune response that gets out of control and becomes dysfunctional.
Yeah. Um, Indeed. So that is one of the hypotheses. But what is also intriguing is that when you have had a frozen shoulder on your right side, it is rarely you will get it again on your right side. Left side, you will get it. You have chance to get it, but once you have it on both shoulders, I'm not aware of any or many people that reported to have, again, a frozen shoulder on one of the sides if they had it. So why do we only get frozen shoulder one time at each side?
Yeah.
That's so we indeed we think about autoimmune disorders, but then it would also be resolved after the 2, 3, 4, 5 years. And if I think about autoimmune disorders, they will always be present in some way, I think. And
They
that
don't
is not
necessarily
something that,
disappear or resolve, do they?
yeah, so I don't know if they indeed completely resolve or disappear, but at least for a subset of patients with frozen shoulder, the frozen shoulder, yeah, resolves, or at least it recovers to a certain point that they will not seek help anymore. And they can live with, yeah, maybe some small restrictions in the end. And for some people, that's fine. For others, it is not. So in that way, I'm not sure if it is really an autoimmune disorder. But there is something very special with it that you will only get it once.
Interesting, isn't it?
Fascinating.
Yeah.
Thank goodness.
Yeah.
Yeah. So I want to wrap up this first session, Michelle. And before I do that, I want to think around, because we've been sort of quite highbrow around some of the philosophies and the theories around that. My understanding is, like Ange mentioned, you have the primary frozen shoulder and then a secondary, like that may come on after your surgery or after some other kind of trauma. I've read about the role of rotator cuff tendinopathy as also a risk factor. And I think about them as a secondary frozen shoulder. Should we continue thinking about them primary and secondary?
I think it's very hard to distinguish what is primary, what is secondary, because when we talk about the secondary, in the initial model, diabetes is also part of the secondary frozen shoulder. But is that really correct?
And so some of these categories might need re-looking at, you thinking, or?
Yeah, or maybe we should not distinguish between primary and secondary. But we should maybe think just about, we don't know exactly what is the cause. That's the frozen shoulder. And when we have surgery, stroke, which is also related to frozen shoulder, then we have a clear cause. And probably the pathophysiologic process is also different. So that makes it also another way of viewing the frozen shoulder, I think. And as you mentioned, the rotator cuff related shoulder pain might also be a variable that will, in the end, develop into a frozen shoulder, because, again, there is some inflammation present, at least in the beginning, in the rotator cuff. So it might also trigger the inflammation within the capsule. So should we say rotator cuff related shoulder pain is a secondary frozen shoulder, or results in a secondary frozen shoulder? We don't know. Maybe it is not the inflammation in the rotator cuff that will develop into the frozen shoulder. Maybe there are some other variables as well that help to develop the frozen shoulder. So in some way, the model with primary and secondary is difficult, in my opinion.
Really fit. And I think the thing that as we're talking through this, I realize that we haven't talked about the role of sex and age. And I typically would be more suspicious in women between the ages of 40 and 60. I should continue my suspicion in that cohort, as Ange and I are representative.
Yes, it is. So, and that also triggered some thoughts about why do women between 40 and 65, 70 develop a frozen shoulder more frequently than men of the same age, than men in general. Probably also
Thoughts?
because of
What do you think here?
hormones. Yeah, it might
hormone.
be hormones, for
Yes.
example, because the female body is changing during that period. So that might be a reason why women are more predisposed to developing a frozen shoulder than men.
Yeah.
But still, why do men also in that age range develop the frozen shoulder? Why do not younger men develop the frozen shoulder? It's quite rare that younger people, especially below 35, develop a frozen shoulder. Why only from that age? Is there so many changes in the human body from 40 years towards 75? I don't know.
Okay. We're going to
But it's
watch this
fascinating.
space. It is fascinating. It really
Yeah.
is. And I've learned, and if I just recap, I guess, the things for clinicians to take away from this as we think through this. A lot of these risk factors, they should be asking a patient that they suspect might have a frozen shoulder. There's a little bit more information around them, and then encouraging people to move in that early stage without mobilizing them or stretching them into end range. That would result perhaps in more scarring and more tissue contraction.
Yes.
Yeah. Ange, what else did you learn in this first segment?
Yeah, no, I think that's probably a good summary. Probably also, I think from what you're saying, Michelle, then it seems like there might also be sort of subgroups, I guess, of patients, and maybe trying to assess whether it's the psychosocial factors, maybe even the pain type, inflammatory type pain, what might be mediating that, and also probably the role of that low grade inflammation and the importance of looking at it, I suppose, as more of a global health issue and maintaining physical activity as part of the management plan as well. So that would probably be some of my other key takeaways.
Yes, I agree on that. Sure.
Do you think there's anything else that we've missed that you think is important for clinicians to be aware of?
Well, maybe something that might be interesting is that we also found in our longitudinal study, we also analyzed the longitudinal correlation between some variables. And what we saw was that there was a good correlation over time between pain intensity and pain catastrophizing and pain vigilance and awareness, if I'm correct. And we see if one of them improves, the other one improves as well. And the only question is now, what improves first? Is it the psychosocial part that improves, or is it the pain intensity that improves? And if one of them improve, we know that the other can also improve. But the question is, what should our focus be on? Is it that the psychosocial factors improve because pain intensity becomes less and they get more familiar with, okay, finally, pain is decreasing, I feel better? Or is it that the treatment was focused on psychosocial factors, and when the psychosocial factors, they understand maybe the disorder better, that then also pain intensity decreases. And that is something interesting for the future that we don't know yet, but that I think that is important to take away, that if some of these variables changes, the other one changes as well.
Yeah. Great. Hey, well, thanks very much. Let's wrap up this session for now, and then we'll move into the work that you've done on exercise and the Delphi study that you can tell me about.
All right, great.
And thanks again to Flawless Motion for supporting this episode. So if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.